Hello, and welcome to this webinar on autism and epilepsy, which has been organized by members of the Pediatric Psychiatric Issues Task Force of the International League Against Epilepsy, the ILAE. My name is Mary Lou Smith. I am a neuropsychologist from the Hospital for Sick Children and the University of Toronto in Canada, and I am a member of this task force, as are all our speakers today. This webinar will cover key issues in understanding, diagnosing, and treating children with epilepsy who also have autism spectrum disorder. The topics will include the epidemiology of autism in children with epilepsy and the evidence with respect to available screening and diagnostic methods and their interpretation. We will investigate whether the treatment of epilepsy can affect autistic features in children. We will discuss practical approaches to managing challenging behaviors in the context of autism spectrum disorder. Identifying target symptoms that may be amenable to both pharmacological and non-pharmacological strategies will be highlighted. The webinar will end with a discussion of the critical question of why epilepsy and autism so often co-occur. Our speakers will address questions at the end of the webinar. Please type your questions into the Q&A box at the bottom of your screen. This webinar is being recorded and it will be available on the ILAE YouTube channel, which you can access from the ILAE website. I'll now introduce our first speaker. Dr. Colin Reilly currently works as an educational psychologist at Young Epilepsy in the UK and as a neuropsychologist in Gothenburg, Sweden, at the Queen Silvia's Children's Hospital. His clinical work primarily focuses on neuropsychological assessment in children with neurological conditions. His research focuses on psychosocial aspects of epilepsy in children, including cognitive and behavioral comorbidities. He is currently chair of the ILAE Task Force on Pediatric Psychiatric Issues. Colin, over to you.
Thank you very much, Mary Lou, and welcome everyone to our webinar. Here are my conflicts of interests. So in today's presentation, I want to sort of get the talk started by focusing on some basics. So what is autism? And why is it important to consider autism in children with epilepsy? Talk a little bit about the prevalence of autism in children with epilepsy and associated factors. Screening and diagnostic instruments. What are the issues one should consider when screening or assessing autism in children with epilepsy? Pose the question, is there a gold standard for assessment of autism in children with epilepsy? And then summarize the main issues with regard to screening and assessment. So what is autism? It's characterized by social communication difficulties, repetitive behaviors or interests, and increased sensory sensitivity, but also cognitive inflexibility. It affects the way people perceive and interact with the world around them. And as we know, including epilepsy, there are a range of co-occurring health conditions that occur at a higher rate than in the general population. It's important to note that autism presents differently across individuals with respect to intellectual disabilities, co-occurring conditions, required support, and the impact on everyday functioning. It has multiple etiologies or causes. In terms of prevalence in the general population, we talked today about prevalence of around 1%, but that has gone up, in recent years. So maybe it's more correct to say between 1% and 2%. And we also know that many children with autism have co-occurring neurodevelopmental or mental health needs. And both DSM-5 and ICD-11 allow for the diagnosis of co-occurring conditions. So just before talking about autism and epilepsy, I think it's important to talk about what conditions commonly co-occur in children with autism, and many of these conditions or symptoms also co-occur in children with epilepsy. So we have at the top here intellectual disability, but even children with autism who don't have intellectual disability often have cognitive difficulties, so difficulties, for example, with executive functioning. ADHD is a common co-occurrence. depression, particularly among teenagers with autism, anxiety, behavior that challenges if the children with autism don't get the right level of support, sleep difficulties, difficulties with language or communication, selective eating. Some children may reach the criteria for avoidant and restrictive feeding intake disorder, or ARFID. Some children have motor difficulties, including developmental coordination disorder, or DCD, and sensory difficulties or differences. So really, there are a lot of other conditions, and it's quite rare to actually have pure autism. So why might one need to consider autism in children with epilepsy? We know that the prevalence of autism is significantly increased in children with epilepsy. And we know that comorbid neurodevelopmental and mental health conditions have a significant impact on quality of life of children with epilepsy. And sometimes that impact is even more than the epileptic seizures. In terms of getting a diagnosis of autism, the child might gain access to specific resources. In some countries, access to resources is based on diagnosis, and autism may be one of those diagnoses that leads to extra support. But hopefully, in assessing and diagnosing autism, that can lead to a better understanding of the child's behavioral and cognitive profile, and hopefully that can lead to provision of optimal supports. So to provide the best supports for children to lead to the best outcomes in terms of quality of life for the children and their families. So in terms of the prevalence of autism in children with epilepsy, a number of studies have been carried out. A systematic review of 19 studies carried out showed a prevalence of 6.3%, so much higher than the 1% in general population. But prevalence will vary significantly depending on population sampled. And particular epilepsy syndromes will have a higher prevalence than more general epilepsy. So this systematic review and meta-analysis suggested a prevalence of 4.7% in general epilepsy, but in particular syndromes such as infantile spasms, it was nearly 20%, focus seizures much higher, and in Dravet syndrome, higher again. So it will depend on the particular population sampled. And in this particular systematic review, there was a lot of different different studies focusing on different epilepsy syndromes, different instruments. So again, there's a lot of variation. The other side of the coin, how many children with autism have epilepsy? There's also obviously an increased rate there as well. And a systematic review published in 2019 found a prevalence of 12.1% of epilepsy in individuals with autism, or autistic individuals. In terms of the neurobehavioral picture in children with epilepsy, it's important to sort of think about autism as one of a number of possible comorbid conditions. This figure comes from a study we carried out in the UK in 2014, and we found that 60% of children with active epilepsy had a DSM-4 disorder, so DSM-4 psychiatric disorder. Autism was the second highest after ADHD, so 21% of the children in this study reached the diagnostic criteria for autism. This was a population-based study and probably higher than the previous systematic review because we had a narrower definition of epilepsy, but we also met every child and undertook quite comprehensive assessments. But children with epilepsy are increased risk of a range of neurodevelopmental and mental health conditions, and autism is one of those. In terms of what factors are associated with the occurrence of autism in children with epilepsy, research shows that the main factor is having intellectual disability. However, it's important to say, and there's not so much evidence of this, but even children without intellectual disability, we found that they were also at an increased risk for autism. Early onset epilepsy, and there will be many children who have early onset epilepsy who also have intellectual disability, but that's also a risk factor. So epilepsy in the first year or second year of life. And of course, when we talk about early onset epilepsy, we must mention developmental and epileptic encephalopathies. So these diseases where there is impairment related to both the underlying etiology, and that's independent of epileptiform activity, and the epileptic encephalopathy. And in terms of autism, the two most studied DEEs would be infantile spasms or infantile epileptic spasm syndrome, as it's now called in the new ILAE classification, and also Dravet syndrome. Other factors which have been looked at include gender. And it's important to say that the male-female ratio in epilepsy is not the same as in the general population. So in epilepsy, it's quite even. In the general population, we usually think of a 3-to-1 and a 4-to-1 in favor of males. But in the epilepsy population, that tends to be, even, so 1-to-1, and just as many females as males. In terms of seizure type, there has been all seizure types can be associated with the occurrence of autism and epilepsy, and there's no clear data on particular seizure types. So in terms of screening for autism in children with epilepsy, it's important to say there are no specific epilepsy-specific instruments, and there's also limited psychometric data in the epilepsy population. So there are no instruments developed particularly for children with epilepsy. And almost all of the instruments which are used and reported on are based on caregiver reports, so proxy reports, some teacher reports as well, but very little in terms of the young person themselves reporting on their own symptoms. This table here gives a list of some of the instruments which have been commonly used in studies of children with epilepsy, and they're also used clinically, but I'm aware there are many other instruments which can be used. And the evaluation here is from my own personal work and some reading of the literature, so it's not definitive. If we take the social communication questionnaire, children have to have a developmental age of 2 years and upwards. It's linked to the Autism Diagnostic Interview revised. I personally feel it's not so good for children of normal cognitive ability. It may not capture autism so well in those children. And I also think that the published cutoff of 15 is a little bit high. And if a child has a score of 11, 12, 13, 14, I think that child should go for further assessment. The Autism Spectrum Screening Questionnaire is also a very useful instrument. It's used for school-age children, so 4 or 5 upwards. And again, it may not be so good in children with more severe intellectual disability, but it is good. There is good coverage of the typical behaviours in children with autism who have normal cognitive ability, and both the parent and teacher can complete this measure. The social responsiveness scale is similar. There are different versions for different age groups, parent and teacher versions. Again, I think it's not ideal for children who have intellectual disability, particularly those children with early onset epilepsy, the DEs in particular. The MCHAT, or modified checklist for autism in toddlers, can go down to quite a young age, so 16 to 30 months. The issue with the MCHAT is you're likely to pick up a lot of children who don't have autism as well. A lot of children who don't have autism are likely to screen positive. So you will have a lot of false positives. That doesn't mean those children don't have developmental or neurodevelopmental difficulties, but they may not all have autism. So when you use the MCHAT, and again, it's focusing on quite a young age, so that's probably the reason why it's not so specific in terms of identifying children with autism. In addition to screening instruments, there are also diagnostic or so-called diagnostic instruments, and these instruments can be very useful as well. They include interviews and observation schedules. A commonly used one is the ADOS, the Autism Diagnostic Observation Schedule. So this is a structured observation with the child, and there are 4 different modules and also a toddler module, depending on the verbal ability of the child. I think using the ADOS is very useful, but it can be more difficult, I think, with older children with low cognitive ability, so severe intellectual disability, and also at the very higher end of the cognitive ability spectrum, but can be quite a useful instrument. The ADI, or the Autism Diagnostic Interview, is also useful in terms of garnering the developmental history and those behaviours associated with autism from caregivers. It's very comprehensive. Again, I feel it's not always so useful for children with normal cognitive ability. Other instruments that can be used include general psychiatric interviews, and I've mentioned 2 of them here. They tend to cover a broad range of psychiatric conditions, and they have specific autism modules. So they won't be as comprehensive as specific autism instruments, but they may be also useful in getting some information from caregivers. So what are the issues to consider in the diagnostic assessment of autism? And I'm talking in general about autism before I go on to the epilepsy specific issues. And it's very important to note that the diagnosis of autism is made on a description of an individual's development and, careful description and observation of their behavior. It's particularly important in terms of social skills to get an idea of social skills in different environments. So school observations, preschool observations can be particularly helpful. And it's also important to consider the child's cognitive level and consider their social skills and their repetitive interests or behaviors in light of their cognitive ability. Developmental level is obviously important. And I personally feel once you go below a developmental level of 1 year of age, it is a little bit more difficult to diagnose autism. And some people may not feel it's so useful if the child, for example, has severe, profound intellectual disability. And it's not a hard and fast cutoff, but I do think that's a good guide. And most of the instruments don't go below or not normed below that particular level. It's important to consider language level as well. Some children will be non-verbal or minimally verbal, and also verbal individuals. So that level of language is also important in terms of considering instruments. In terms of chronological age, I think it's relatively seldom that a child will be diagnosed below 2 years of age. Even though one can see behaviors indicative of autism between sort of 12 and 24 months, there are relatively few children who are diagnosed. But once you go into sort of 24 months, 2 to 3, I think you're much more sure of your diagnosis of autism. Before that, you might end up assessing a child who has developmental difficulties, but it might be difficult to say that it is autism, and there may be a lot of other things going on. It's important to consider adaptive behavior. So how independent is the child? Many autistic children can perform particular skills, but they don't often do it. And parents will say that, well, they can do that, but they don't often do it in everyday functioning. And that can be very important in the assessment to know that. And in general, the choice of instrument in diagnosing autism or assessing autism will depend on age, cognition and development, but also resources available and the actual goal of the assessment. What is the goal of the assessment? Is it to look, is it just to look at autism, or is it, as it should be, to look at the child's needs in a broad sense? And of course, there are other possible conditions, symptoms, difficulties that need to be considered. So it may not be autism, and what are those conditions? And early on in the talk, I mentioned some possible co-occurring conditions that might be co-occurring, but actually might be important in terms of differential diagnosis. There are also some epilepsy-specific issues which I think are important. And we do know that sometimes children with epilepsy with autism might be missed. The diagnosis might be a little bit later than one might have anticipated if the child didn't have epilepsy. And there is the risk of diagnostic overshadowing, where the need to focus on epilepsy, the need to treat epilepsy, frequent epilepsy seizures might overshadow the need to also look at the child's neurodevelopment. And that could lead to later assessment of autism and other neurodevelopmental problems. Of course, children with epilepsy may have unusual mannerisms, movements, and behaviors, which we also see in autism. And it's important to have somebody familiar with epilepsy in the team when autism is being considered. So have an epileptologist on board as well when autism is being considered, to think a little bit about the semiology of the child's seizures, to separate out what is what. Video EEG may also be useful in this regard. Sometimes the question of epilepsy and autistic regression comes up. And is epilepsy a major, contributing factor to the regression we often see reported in children with autism? But in general, although it may contribute in some cases, it's thought to play a relatively minor role in the autism population as a whole, and rates of epilepsy in regression and non-regression groups tend to be quite similar, as this study from 2019 shows. Sometimes we get asked in our epilepsy clinic about when is a good time to do an autism assessment and when is not a good time. And, it might be that the child is having very frequent seizures, And it might be that people want to wait and wait, but the problem with waiting and waiting, as we know, is many children, with epilepsy will not be seizure free, and therefore it's important that you agree on that things aren't going to get so much better. So we need to go ahead with a neurodevelopmental assessment, and we can't wait for too long. So optimizing the epilepsy treatment is important, and it's important to recognize occasionally that seizures or the side effects of anti-epileptic medication may actually conceal the child's true behavior. Just a couple of more epilepsy-specific issues before I finish up. We have this paper published in 2021, and a very interesting paper suggesting that in some cases of epilepsy and autism may present slightly differently. And what those differences might be, so it might be that the autism features appear close to the onset of the epilepsy. And we see this in spike and wave activity in sleep, which may lead to developmental or epileptic encephalopathy. So the age of onset might be slightly later. We might see children with epilepsy which appear to be quite socially approaching, but they have an impaired ability to understand social interactions. In terms of masking of autism, we see potentially sometimes, for example, after epilepsy surgery, not so often that we see clearer picture in terms of autistic features. And again, some children with epilepsy will have multiple disabilities, which can make it more difficult to use our standardized instruments. The barriers to screening and assessment, access to expertise, access to instruments in terms of cost, time needed. And again, I mentioned the validity in particular populations. There may be cultural and linguistic factors as well. And, sometimes we may not have access to the informant regarding the child's developmental history, which is so important in autism. And again, in terms of recent research, we know that sometimes females may be missed as they may be better in terms of verbal ability or social skills, but they're actually masking their autistic behavior. The gold standard, I think, in this population is always going to be clinical diagnosis. So multidisciplinary team, experienced clinicians, having somebody with epilepsy in the team. And it's very important, this quote from Cathy Lord, which I won't read in full, but it's very important not to over-rely on our so-called diagnostic instrument or our screening instruments, that they can play a very important role, but it will be important to consider other factors as well. And to include all these other factors in terms of the assessment of the child is particularly important. And obviously, it's important to try and optimize epilepsy treatment so you get a valid assessment. To summarize, children with epilepsy are at high risk of autism, so it is important to consider screening or surveillance. If there isn't appropriate screening instruments, just making sure everybody in the team knows what autism is very important. And there are particular high-risk groups where I think screening is vital, children with intellectual disability and early onset epilepsies. It is important to individualize the approach in terms of selecting screening instruments and assessment instruments, and don't over-rely or over-interpret the results of instruments. It is important to consider epilepsy factors, but don't wait too long. Don't wait for the child to be seizure-free or, because that might never happen. It's important to consider possible differential diagnosis, but also that children with autism and epilepsy may have other co-occurring conditions as well. And one-time assessment may not be definitive. It's important to remember that sometimes, and we talked about that paper previously, there may be a fluctuating phenotype, so you may have to rescreen, particularly with children who are close to cutoffs, are close to what you might think is autism, but actually don't fulfill the full criteria. But the goal must always be screening and assessment to identify the child's needs and leading to subsequent supports for the child and family, which hopefully can improve quality of life. Thank you very much.
Thank you, Colin, for that wonderful overview and those insightful comments. All right, our next speaker is Professor Stephane Auvin, who is an epileptologist and pediatric neurologist at the Robert Debré University Hospital and the Paris Cité University in Paris. His research addresses early onset pediatric epilepsies, epilepsy drug development, and the rare epilepsies. Professor Auvin is the past chair of the ILAE Pediatric Commission. Unfortunately, he is not with us in person right now, but we do have a recording of his presentation, which I'll show now.
Good morning, everybody. Welcome again to this webinar, and thanks for the task force on psychiatric comorbidity of the Pediatric Commission to have organized this symposium. Today's webinar. Then today I will address can treating epilepsy affect autistic features in children. Then first, before starting, this is my disclosures. Today we will try to go through different topics. First, even without speaking epilepsy, I would like to discuss if using anti-seizure medication can improve autism spectrum disorder symptoms. And then we will briefly say a word about the interrelationship between epilepsy and autism spectrum disorder, and then try to look at both scenarios, treating epilepsy in children with autism spectrum disorder that develop epilepsy, but also treating epilepsy in children that have developed symptoms of autism spectrum disorder with different look on specific syndromes, and to discuss if there is any way for prevention of autism spectrum disorder in this patient. And then let's start by the fact that some people look at the effect of anti-seizure medication of autism spectrum disorder's features. And then I just summarize in one slide. This is a meta-analysis that is 10 years old. There are very few studies more, real control studies. And then the first conclusion is there is no benefit on autism spectrum disorder symptoms of using anti-seizure medication. It has been done with 7 studies. 5 was looking at monotherapies, 2 was add-on, and there is no effect on the autism spectrum disorder, looking at different scales. Of course, for autism spectrum disorder and epilepsy, there is a bidirectional relationship. We know that the frequency of epilepsy in autism spectrum disorder is higher than in the general population. And in that case, we know there is a bimodal distribution with a peak of incidence in young infants and in adolescents. We know that epilepsy in autism spectrum disorder is even higher in the patient with autism spectrum disorder compared to their siblings, and suggesting that it's more than the genetic background, for example. But we also know that this relationship is bidirectional, meaning that we know that some patients with epilepsy, in particular early onset, in particular developmental epileptic encephalopathy, and sometimes some etiology, are associated with a higher risk of autism spectrum disorder. Then, for example, we know that in some conditions, there is a co-occurrence of autism spectrum disorder and epilepsy, like in tuberous sclerosis complex, like in CDKL5, or also in Dravet, even if the communication or the interaction and sociability is very good in these patients, they might fulfill the criteria for autism spectrum disorder. Then let's start by the first scenario, patients with autism spectrum disorder that develop epilepsy, how to treat them. And before saying that, I just would like to briefly mention something that is a bit outside the scope of treatment today, but diagnosis of epilepsy in autism spectrum disorder is not easy. Of course, in case of generalized tonic-clonic seizures, it's an easy diagnosis because everybody will, recognize what is a generalized tonic-clonic seizures. But for starting episodes, is it absences? Is it typical absences? Is it atypical absences? Is it focal onset seizures with awareness impairment? It's sometimes very difficult. And when you look at the literature, it's definitively unclear what type of seizures, what type of syndrome you have. And even sometimes, and this is a very nice study that has been done, trying to identify what are the paroxysmal events in 22 children with autism spectrum disorder that was referred for seizure evaluation. Of course, as you know, EEG recording is not an easy task in these patients. And then they look at, they were able to record 15 of these patients, and none of these events, paroxysmal events that was referred for a seizure, at the end was an epileptic seizure. Then it's not very easy. In addition, when you record the patient with autism spectrum disorder, and I put few studies, there are more, you know that you can, even with outside epilepsy, find a lot of epileptiform abnormality. And if you record routinely the patient, it's 1/3 of these patients that might have interictal abnormality, like epileptic form abnormalities. But the more you record and the more you find, could be up to 60% of these patients. And we know that with the level of intellectual disability, the rate of epileptic form abnormality will increase. Meaning that abnormal EEG, even like very strong abnormal EEG, is not enough to make the diagnosis in this patient. And then I really like this study. It's not rocket science. I mean, the methods are not very robust. It's a bit old now, but I mean, it's something that looking at clinical practice is very meaningful in my view. Then it is a survey that has been done from to parents. It has been announced by email and website to Autism Spectrum Disorder Supporting Group. And then the survey was conducted online. They got response for more than 700 children with seizures and 200, almost 300 controls, autism spectrum disorder without seizures. And they asked different questions, and one of the questions was about treatment. They grouped treatment by group of anti-seizure medications, and they call them cluster, like the cluster 1 was valproate, lamotrigine, levetiracetam, ethosuximide, and the cluster 2 was phenytoin, clonazepam, carbamazepine, oxcarbazepine, topiramate, gabapentin, zonisamide, felbamate, and the subcluster 3 was phenobarb. And then, for example, here is the different anti-seizure medication of the cluster 1, valproate, lamotrigine, levetiracetam, and ethosuximide. And they use like a scale, no change or better, much better, worse or much worse. And when they ask on the effect on seizure in these patients, hopefully it's better when you use anti-seizure medications in this patient. But then when you look at sleep, communication, behavior, attention, mood, you can see that it's almost always worse. Meaning that we have to be very cautious when we use anti-seizure medication to treat epilepsy in a patient with autism spectrum disorder. And then it's a general rule that I would like to remind you, something that is very well known. When you increase the amount of anti-seizure medication, after a while, you reach some plateau for the efficacy. But when you increase the same amount, the side effects could increase exponentially, meaning that the general rule, start low, go slow, is very important because these patients with autism spectrum disorder look very sensitive to a side effect. That is something very important. This is kind of a special population, and there is unfortunately no trial, no controlled trial, no very robust methods to assess the effect of anti-seizure medication in a patient with autism spectrum disorder that develop epilepsy. Let's move now the other way around, patients with epilepsy that develop symptoms of autism spectrum disorder. What we know about them, how to treat them, and treating them, does it change anything on autism spectrum disorder? Then first, I would like to use this study. It's a recent study. It's a study that has been conducted in London. This is a group that is assessing patients with epilepsy for developmental disorder, and they are doing like large screening. You can see that they report their historical cohort, about 500 patients, and at the end, 30% of them met the criteria for autism spectrum disorder. You can see the etiologies, and for example, a part of the SCN1A mutation, a part of the GRIN2D mutation, a part of what we used to call EECSWS, that is now epileptic encephalopathy with so spike and wave activation in sleep. I will say a word about that. And then some other conditions that I already mentioned, for example, like tuberous sclerosis complex. When you look at the patient with autism spectrum disorder, there are few things that are interesting. First, you can see that the regression history is not that frequent in this cohort. Same thing, the fact that some of these patients might develop autism spectrum disorder after the age of 4, but they following a normal early social communication is still very frequent, and it's not because the patient still have or had an early social communications skill very high that means it's not autism spectrum disorder. And then some of the symptoms sometimes fluctuate, and it's something that was mentioned. For example, you can see here, I just moved this, that the autism spectrum diagnosis was removed in few of these patients. It's unclear if it was related to therapy, to anti-seizure medication, to seizure freedom, and it's still something that we have to investigate. Then speaking about the cognitive regression, you know that in autism spectrum disorder, you can have regression, and there is one syndrome where you can have regression. It's the epileptic encephalopathy with slow spike and wave in sleep. The most common scenario, there are several, but the most common scenario is around the age of 6. A patient that had few seizures, mostly seizures that was within a syndrome that could be a self-limited epilepsy, could be select or SELAF. And then the patient have an increase in the seizure frequency associated with regression. And sometimes this regression is not only on cognition, could be also on behavior with autistic features. If by chance with your treatment, you are able to control the seizure and remove the activation of the slow spike and wave during sleep, the patient might recover. Of course, the risk is relapse, but it's something that is very well known now. I just put in this table the criteria from the 2022 ILAE classification, and then what is the core of the syndrome is the cognitive, behavior, or motor regression on plateauing related to the spike and wave activation in sleep. This spike and wave activation is a slow spike and wave abnormality in non-REM sleep, and then this abnormality is markedly increased. As you can see, there is no mandatory percentage in this diagnosis criteria, and we have to further understand what is the role of the percentage of these abnormalities. Then, just to put in a slide what is different, we know that some of these patients with autism spectrum disorder have regression. As I mentioned, a lot of them have abnormal EEG, but this regression is usually earlier. This regression is usually not associated with seizures, meaning that the typical scenario are really a bit different. You don't need to treat this patient with anti-seizure medication. As I mentioned earlier, there is no effect on the autistic features or symptoms, while if your diagnosis of epileptic encephalopathy with slow spike and wave activation is clear, treating the patient might reverse the symptoms in this patient. I just would like to briefly mention Dravet syndrome. As you can see in this large cohort of 241 patients published by the group of Samir Zuberi and Andrea Bronklos, the autistic features are increasing over the ages, and it's something that is known. With more detailed study, you can see in this 35 patients with Dravet, with most of them with intellectual disability, they found that 30% of these patients made the criteria for autism spectrum disorder, with a good correlation between intellectual disability and autism spectrum disorder. Once again, in these patients, communication skill was usually well preserved, not fully preserved, but still very kind of preserved, that could be lead to some difficulty for the diagnosis, as mentioned also in other talk today. And then, if you think about these features, is there any effective treatment treating the seizure? Does it change something? Is there any contraindicated medication related to these autistic features? Unfortunately, it's unclear. What we know about cognition, but almost nothing on behavior, in the fact that in Dravet, we know that the gene mutation is doing something from experimental study, putting some defect on the gene expression, even without seizures in animal models, could lead to some cognitive deficit. From the large cohort from Scotland, we know that the number of status epilepticus early in childhood might have an impact for a worse nursing outcome. And from the Dutch study, we know that sodium channel blocker that increase the seizure frequency most of the time might expose to a worse cognitive outcome. And in that case, it's a long time exposure because, as you can see here, the group separated in two parts after or before 11 months of treatment, you can just change the outcome and see the difference after this time of exposure, meaning that the increase in the seizure frequency for a long time, or even the improvement for the long time, almost 1 year, can change the cognitive prognosis in this patient. But for autism spectrum disorder, it's still very unclear, to be honest. Then in conclusion, we have no evidence for improvement of any anti-seizure autism spectrum disorder feature with anti-seizure medication. Even the EEG is very frequently abnormal. You might worsen the behavior as we discussed today. Anti-seizure medication should be handled very carefully in patients with autism spectrum disorders that develop epilepsy. Even if you are could be very effective, most of the time you disrupt part of behavior, sleep, interaction, then start low and go slow for the titration. In children with epilepsy that develop autism spectrum disorder, I think we need an individual approach like any developmental epileptic encephalopathy. Always try to see what is the part that is developmental, what is the part that is related to the epileptic activity, and then step by step, try to see if you improve the patient or not. If you improve the patient when there is an epileptic encephalopathy component, you might improve or even reverse some of these symptoms, and maybe one of the typical examples is epileptic encephalopathy with spike and wave activation in sleep. But in most of these patients, no change will come with the treatment of seizures, or maybe you will need a very long time of improvement to see any change because there is a developmental component that is very important. Then thank you for your attention, and I hope you enjoy this webinar today. Thank you.
Let's turn now to our next speaker, Dr. J. Salpekar. He is the director of the Neuropsychiatry Center at the Kennedy Krieger Institute and is an associate professor of psychiatry and neurology at Johns Hopkins University in Baltimore. He is a longtime scholar in the overlap between epilepsy and psychiatric illness. Dr. Solpikar is a distinguished member of the American Epilepsy Society, the American Neuropsychiatric Association, and the American Academy of Child and Adolescent Psychiatry. The American Epilepsy Society has honored him with the Rebecca Goldman Kaufman Award for Ethical Neuropsychiatry. So Dr. Salpekar, if you'd like to share your slides, thank you.
Thanks so much. So it's my pleasure to be here and talk to you all on this webinar about psychiatric difficulties in children with autism. We've heard a lot about epilepsy already, and I think you can already glean that there's a lot of overlap between autism and epilepsy, not only phenomenologically with epileptiform findings on EEGs, but also in terms of symptomatically, and we've heard a little bit about the bidirectional relationship. So I'm going to depart from epilepsy just a little bit and highlight autism and address our overlap from that direction, and then see if it can help us with practical treatment strategies. So these are my disclosures. I don't have an active consultantship right now, but we still have an ongoing study for our institution only, and we're making good progress with that. Our objectives are to think about the overlap, the range of treatments, and emphasizing practical. So we've seen a lot of overlap, and we know that that some of these connections can be related to both epilepsy and autism spectrum disorder. We know that a lot of our symptoms of autism depend upon multiple brain regions. And a lot of people talk about cortical and subcortical connections. Some people like to think about laterality, right and left, and corpus callosum, how that might influence social reciprocity and interactivity. And we know that those things are problems for people with autism. That can be a big issue for thinking about how symptomatically we identify problems and try to address them. The fault might be, for both conditions, might be in these interneurons, and there might be GABA interneurons that are faulty in both conditions. You think a lot about inhibition problems, and that, of course, is where GABA comes in. But then a long time theory for autism has been excess glutamate transmission or hyperexcitability. And there have been pretty reasonable studies that look at excess hyperactivity or hyperexcitability. And of course, that's a problem for epilepsy too. If you've got neurons or networks that are on a hair trigger and that can fire when we don't need them to switch on, then that can lead to seizures or seizure-like phenomenon, even if they're subclinical. And it might, in some manner, explain some of the intolerability or social overload, stimuli overload that can happen in autism spectrum disorder. So anomalous connectivity of some sort with either lack of inhibition or excess excitability might actually be at the core of both conditions. So we talked about hyperexcitability. A lot of our medicines will target this hyperexcitability. And as you've already seen, isolated spikes, nonspecific discharges, they may be common in autism spectrum disorder. I'll add they may be common in other psychiatric illnesses as well. We see a little bit of a signal in ADHD. And sometimes people think about delta to theta ratios or other such quantitative analyses. It might make a difference for different psychiatric conditions. Now, and even if we get these small bursts, they may not coalesce into actual seizures that are textbook, neat and tidy. So any epileptologist is not going to say that they're seizures, but it doesn't mean that they're nothing. It means that something is going on that is electrical in nature that can be identifiable, and maybe it correlates to symptoms, maybe it doesn't, maybe it's a shock to the system in some manner. So we see pathophysiologically some sort of overlap, even if we can't describe it or clarify it in solid detail enough for us to really make a difference. So then what we're stuck with is symptoms. And the call will come to your office, and usually it's some sort of aggressive reaction or discontrol or impulsive reaction. And we have to go in a step-by-step assessment, a step-by-step analysis. The first step is to rule out the underlying medical condition. Is there any sort of adverse reaction, side effect, interactivity? A lot of medicines that cause sedation or grogginess can lead to behavior problems because naturally anybody is going to try to fight that. They're going to try to oppose the sedation or grogginess, and sometimes the result will be discontrol. Sometimes actual discontrol or impulsive reaction means a physiologic need of some sort, or a homeostatic need, if you will. Aggression might actually reflect hunger or some sort of need for change of scene, some elimination difficulty to use the restroom or facility in some manner can be discomforting enough to lead to disruptive behavior. So what we want to do is get detail. We want to train caregivers, anybody who's an observer, to give us some information about what the details are in terms of transitions, proximity, time of day, ambient environment, new visitors, even weather, humidity, lights, presence of caregivers. All these things are very important to understand what is leading to the disruption. And then, of course, we can sometimes see that irritability or aggression, sometimes hyperexcitability in terms of physical activity, have been historically viewed as constitutive elements of autism spectrum disorder, yet they might also be relevant in the context of seizures. Anyway, a whole host of things that can lead to disruption, any change in staff or peers, disagreements, family visits are common issues that lead to behavior exacerbations, any change in routine, any type of excitement regarding holidays or important occasions. Very commonly, those things will lead to disruptions or disruptive behavior. And what that means then is that we might not have to use a medicine. We can sometimes use non-pharmacologic interventions and have that be very successful in addressing some of these behaviors. Structure. Most people, not necessarily people with autism or autism spectrum disorder or epilepsy, overlapping, do better with the schedule or with predictability or routine. Well, why not for our patients then? If we have a structure and predictability, then they know what to expect. Then there's not the ambiguity that can sometimes lead to disorientation or uncertainty or even anxiety. Stable caregiver. Note that if there's any change in a caregiver, it doesn't always happen in real time. And I get the question that comes many times, well, we had a new staff person that started 2 weeks ago. Why are we having the disruptions now? Well, sometimes there's a lag time. Uh, children, adolescents, adults with autism, they might be able to adjust to short-term changes, but once they realize that this is actually seeming to be a permanent change, they might get a little agitated. So they may not have the reaction till a week or two later. And then just in any sort of set of treatments for non-pharmacologic strategies, we want to have social skills. As much as possible, don't allow social isolation. Sometimes that's necessary, but we want to have rudimentary social greetings. It helps an individual be more capable, more competent in interacting with the world, their environment, and to get their needs met as well. And that leads to communication, even facilitated communication for people who are nonverbal. That can be very helpful. Psychotherapy can sometimes be helpful too, and essentially just putting words to feelings, identifying emotional states, and then try to have the same routines in different settings. Now, the other thing that comes up a lot of times is that we don't always have the same criteria for individuals with autism spectrum disorder as we do for neurotypical individuals or people on a typical neurologic pathway. If you're neurodiverse in some way, your symptoms are going to be different. And it's going to be difficult to look at a set of criteria in DSM or any other categorical diagnostic approach and then be able to check boxes and come up with diagnoses. We might have equivalent symptoms that reflect, say, mania or bipolar disorder. And instead of having flight of ideas or racing thoughts or pressured speech, we might have pacing or screaming even, or rocking and self-injurious behavior even, and that might reflect actual manic behaviors in this population. And at the same time, depressive symptoms, we may not have somebody that says, oh, I'm depressed, or I feel terrible, or I'm not happy. Um, I just feel unfulfilled in my life. Well, you're not going to get that answer very often. We don't get that answer very often in pediatrics, let alone in people with autism spectrum disorders, especially overlapping with epilepsy. But we might see preoccupation or perseveration about topics of funerals or death or deceased relatives. We might see self-deprecating statements. And I've heard individuals tell me, well, nobody likes me, I have autism. And certainly it's heartbreaking to hear that type of thing. But when we hear it a lot, well, that's a depressive equivalent. And then withdrawal. And also keep in mind that agitation sometimes reflects depression. Doesn't always reflect mania or anything else. Sometimes it is actually depression. Now, this is just a very rough flow chart, and I've been teaching this to caregivers and to our trainees for a long, long time. Let's just start with the behavior dimension. And again, this is departing from our DSM criteria where we have to check boxes and get 5 out of 8 or whatever the number is. Let's just start with aggression and let's get details. And if we can think in terms of aggression, whether it's spontaneous versus reactive, that can go a long way to help us decide about treatment. A spontaneous aggression is something that happens with very little identifiable antecedents. If we have a patient who is very comfortable, very happy doing their activities, and then suddenly they jump up and start throwing things, screaming, thrashing around, maybe even acting self-injurious behavior, well, that's a spontaneous aggression. If instead someone is comfortable and sitting and then up here or a staff person or a caregiver comes in and says, it's time to get up and go to lunch. It's time to do this. We have to do a transition. And then the person has an aggressive reaction. Well, that's reactive. And that helps us decide whether this is an environmental condition, whether we are better off using behavior modification or not. If it's a spontaneous behavior outburst, then we think that there's something intrinsic to the brain, and maybe we need to use a medicine to treat that intrinsic problem. If it's a reactive aggression, then we think more about environmental modification. Now, the exceptions, of course, are if this is a rapidly escalating aggression, well, then we still might be in medication territory. Similarly, if we have a very mild spontaneous outburst, well, we still might be able to use behavior modification. We may not be in medication territory at that point. So the other thing to keep in mind is that we can't always look at diagnoses and FDA indications or other regulatory body indications for using medicines. We're going to have to look at target symptoms. And those targets are often aggression, repetitive behavior, sleep disruption, hyperactivity. And those are going to be the things that we will use for our metrics in terms of how to treat and how to redirect. In the United States, we have 2 FDA indicated medicines for irritability. And that's what both of these indications are, irritability associated with autism. And those are 2 antipsychotics, risperidone and aripiprazole. There's very robust data, actually, randomized, double-blind, placebo-controlled studies. This is a very sophisticated research study, multi-site. They're called RUPS, Research Units of Pediatric Psychopharmacology. And I'm sure many people have heard about those. The primary outcome was the irritability subscale of the aberrant behavior checklist, and that's a good scale. It's a good way to have a tangible, objective measure. Note that there were side effects reported too, including weight gain, sometimes sedation. With both of these medicines, there's some sense that aripiprazole might have a little bit less weight gain than risperidone, but those are our 2 FDA indicated medicines. But it doesn't mean that those are the only ones that can be effective. And I hope everybody can see this slide. There's a lot of detail on it, and this is just a cursory overview. And what you can see is that, sure, there have been good studies with risperidone and aripiprazole, but there's been smaller studies and some other studies looking at olanzapine or lorazepam, and looking at the same types of outcomes, essentially looking at repetitive behavior, and that's what the CY box is, and that's the OCD scale, and looking at some improvement. Now, the results are mixed. A little bit of improvement with olanzapine, but a very small study. No significant effect on irritability or lorazepam. But keep in mind that just even if we don't have a significant difference, it doesn't mean that subpopulations don't have some improvement. So any of these medicines, we still might get a signal for a subset. And although the global criteria, if we have people who have irritability on a subscale of the ABC and autism spectrum plus epilepsy, and only some of them respond, well, maybe it's a subtype, and maybe we're not identifying the subtype well enough. And for a lot of these studies, that might be the case. So keep that in mind, that our individual patients are going to be our best. Our N of 1 is going to be our best study, and we'll have to be a little bit nimble about using these medicines. And that also means that we're not only going to use antipsychotics. Sometimes we're going to use antidepressants, especially if we have these symptom equivalents that could reflect depression. Now, note that the caveat is that in pediatrics, antidepressants in children without autism spectrum disorder are really modestly effective. Now, that's for prepubertal children. For adolescents, antidepressants, especially SSRIs, are significantly more effective, and we have pretty good data with fluoxetine for younger children, and then for adolescents with a few different studies. But we have some negative studies as well with citalopram, even though clinically we use citalopram all the time. Then an open label study of escitalopram, which showed some improvements, some mixed results. And there might be genetic profiles that suggest different differential responses to different medicines. Even that's a little bit of an overgeneralization, and we're not getting too specific. I mean, we say 5-HT uptake. Okay, we don't always know what that means. We're trying to learn about this, but it's difficult business trying to separate out responses with heterogeneous conditions, heterogeneous medication effects. But the reality is that we have some evidence of this class of medicines that can be effective, so we should pay attention to it. There's a lot of overlap with anti-anxiety agents as well as antidepressants, and most of the time, antidepressants might be our first-line agents for anxiety as well as depression. We can use buspirone even for repetitive behavior, and sometimes benzodiazepines. There haven't been controlled studies in autism spectrum disorder, but they're very commonly used for catatonia and might even be first-line agents, at least in terms of pharmacologic strategies for catatonia. This is not your the old definition of catatonia. We can have agitated catatonia. We can have restricted range of activity catatonia. This is sort of cutting edge in terms of pediatric neuropsychiatry and adult neuropsychiatry, how we define that. And these are the first choices, benzodiazepines, and we might be able to use that for autism spectrum disorder too. Note that the side effects of paradoxical hyperactivity can be very significant, especially in anybody with a developmental epileptic encephalopathy or autism spectrum disorder or other intellectual or developmental disability. Paradoxical hyperactivity can be common with benzodiazepines. So with that caution, we can proceed. And then, of course, our anticonvulsant medicines. Anticonvulsants are terrific. Now, I know that we're saying anti-seizure medicines now, and that's an accurate reflection that our medicines treat seizures. They don't necessarily treat epilepsy. And then convulsions maybe are even a rougher term. But we're not reversing the pathophysiologic problems with epilepsy with the medicine, but we may be able to correct seizures. Well, luckily, we can also maybe target impulsivity, rage outbursts, mood lability, and a lot of times seizure control and behavior control overlap and go hand in hand. And we use a lot of different medicines. We have ongoing studies with cannabidiol right now, and we completed a study with clobazam, which was very intriguing about looking at anxiety, particularly generalized anxiety overlapping with epilepsy. So we might get a little bit more mileage out of an anti-seizure medicine, looking at treating seizures plus psychiatric symptoms at the same time. And here's, I mean, a lot of people are familiar with these studies. I know there've been some pretty good randomized controlled trials, some even with crossover designs, with placebo control, some adjuncts, and we can get a signal with valproate, even levetiracetam. Levetiracetam has a bad reputation, rightly so in many ways, but don't forget it can also maybe improve things. It didn't in this study, but I've seen it improve some people. And similarly, lamotrigine with no improvement in this study, but sometimes we can get a signal out of that too. Anyway, in sum, note that there's frequent neurologic comorbidity with autism spectrum disorder. And if we use medicines or treatment strategies that can address seizures, sometimes we improve behavior at the same time. Note that non-pharmacologic strategies and doing a little detective work about coincident symptoms or context is often a first-line treatment. If we have a rapidly escalating aggression or spontaneous outburst, that might indicate that we're in medication territory and suggest that we should even use an anti-seizure medicine as a first line, or at least to consider it. But also note that our best evidence at this point is with risperidone and aripiprazole for irritability or extreme irritability associated with autism. That's our most robust data. But I'll stop there, and thank you very much for your attention.
Thank you, Jay, for a great overview. I'm going to move to our last presentation. Our last speaker is Dr. Nicola Specchio, who is a neurologist and epileptologist, and he is the head of the Rare and Complex Epilepsy Unit in the Department of Neuroscience. at the Bambino Gesù Children's Hospital in Rome. He has championed global awareness of epileptic syndromes and the genetics of epilepsy, and he also works in the field of pre-surgical evaluation of patients with drug-resistant epilepsies. And Dr. Specchio was the recipient of the 2021 ILAE Ambassador for Epilepsy Award.
Good day, ladies and gentlemen. It's a great pleasure to be here in this webinar, this Pediatric Psychiatric Issue Task Force webinar. It will be really a great pleasure to close the meeting and to discuss with you today about why do epilepsy and autism often occur. So let me start explaining how much is complex this topic, as far as there are a number of neurobiological overlapping in between epilepsy and autism, and a number of situations, of clinical situations in which you may find both epilepsy and autism, as was previously discussed by previous speakers. So these are my disclosures for today's meeting. And this is what I would like to start with. So what are the priorities? So definitely, when we discuss about both epilepsy and autistic spectrum disorder, we need to improve the understanding of what is ASD in patients with epilepsy. We need to try to develop what overall the cognitive disabilities and translating the genetic knowledge to improve the cure of patients. And last but not least, of course, improving quality of life. And everything is based on the peculiar interactions in between autistic spectrum disorders and epilepsy. So starting with this slide, I mean, you see here this nice paper. It's quite a complex draw, but you may find here that in the patients with developmental impairment and epilepsy, and specifically in patients with autistic spectrum disorder, and you can find it here highlighted, you have a number of genes that are shared in between ASD and epilepsy, and there is up to one quarter of individuals with the neurodevelopmental disorders associated are associated with epilepsy, and several genes have been implicated, as I was just mentioning, in both neurodevelopmental disorders and epilepsy disorders. So what are the common types of comorbidities? I'm not going through all of those, but just wanted to point out that autistic spectrum disorder is something that is frequently seen, as pointed out by the previous speakers. And you see here that there can be different mechanisms based on this specific association. I will move now to the peculiar association and giving you some examples of what are the possible associations between autistic spectrum disorder and epilepsy. And let's start with this very easy and simple. So independence. So the two conditions can be independently seen in a given patient. This is unlikely, but it can happen, and can be considered as a distinct condition without real causal relationship. Even if, as I was mentioning before, this is quite unlikely because you have at least 30% of co-occurrence rate in between the two disorders. But let's move forward and let's see how much can turn to be complicated, this situation. So firstly, thinking about patients with epilepsy or epileptiform EEG abnormalities, they may show autistic spectrum disorders or autistic regression. And epilepsy in some patients can lead to some of those symptoms. And this is what we usually see in patients with the typical epileptic encephalopathy. But also, also abnormal brain circuitry that are based that are behind, the autistic spectrum disorder can provoke epilepsy. And how does this happens in the first situation? So you have epileptiform discharges. Epileptiform discharges may alter in some way the brain areas that are even distant to the epileptogenic focus, but they're really connected with this. And this was nicely documented with the fMRI studies. Or you may have alteration of neural development or abnormal information processing, bringing to cognition disturbances, but also to autistic spectrum disorders. And there is another situation which can should be taken into account, which is the common pathology, and which is the most common, as I was mentioning before. Common pathology can be due to genetic factors or due to structural lesions in the brain, or can be multifactorial. And you see here, this ASD can go in epilepsy and vice versa. But you see, there are common neurobiological antecedents that may lead to abnormal brain development and resulting both in epilepsy and in autistic spectrum disorder. Let me show you just an example of a patient with a structural epilepsy presenting with autistic spectrum disorder. And you see here, this is a patient with right temporal lobe epilepsy with early onset. He had surgery at the age of 2 years. And you see here had a right temporal resection. He was seizure-free soon after epilepsy onset, but look at non-verbal. Look at him, how is and this kind of vocalization, and he was really seizure-free since the age of 2 years. So it seems that there is, in this case, this is not the epilepsy that is responsible of the autistic spectrum disorder, but maybe there is a situation which is based on a common neurobiological process. So let's move now on the genetic mechanisms and on the other causal mechanisms of epilepsy and comorbid autism. This was a review we did a year ago, and you see here there may be different genes and different genetic variants responsible for synaptic dysfunction, starting from ion channels, moving through genes involved in transcription regulation, and then you have very typically, and I will show you a couple of examples later, genes involved in mTOR pathway, and genes involved in synaptic function and structure. So what it happens here, it happens that the abnormal synaptic functions is responsible of what? Of unbalance between excitatory and inhibitory mechanism, is responsible of issues with synaptic plasticity, and last but not least, the excessive growth, synaptic growth and cellular growth. So now let's move to analyzing some of those situations. And I was discussing about cellular and synaptic growth in ASD and abnormal balance between excitation and inhibition. So the aberrant protein translation may lead to overgrowth of the brain, which is a process that underlines the abnormal connectivity and synaptic functions. And this is one of the mechanisms that is documented in autistic spectrum disorder. Also, the imbalance between excitatory and inhibitory mechanisms can result in an abnormal and altered neuronal function, leading to autistic spectrum disorder, impaired communication, and also definitely leading to epilepsy. And you see, we do have definitely some genes that are most commonly seen and most commonly responsible, most commonly seen in both autistic spectrum disorder and epilepsy. And remember the four groups of genes, and here you have some examples of, for example, here are genes involved in synaptic function and structure, and SHANK3 is one of them, CDKL5, STXBP1, PCDH19, all situations that we know very well in which patients, they do present with drug-resistant epilepsy or developmental and epileptic encephalopathy associated with autistic spectrum disorder. You have this situation also in ion channels, and you have SCN2A, 8A, 1A, GREEN2, and different other genes, or genes related in the mTOR pathway. And I'll show you a little bit later an example of TSC patients. And lastly, patients involved in transcription regulation. And here you have some examples. So these are only few of them. It's only an explicative picture of the real situation. What we know is that here there are different papers in which is clearly reported the percentage of patients with autistic spectrum disorder and in genetic epilepsies. And you see here that you may go from the 100%, I mean all patients like in SHANK3 and CDKL5, as I mentioned earlier, to less frequently seen in in HCM1 or KCN1A. Okay, let's move forward and let's see what are the other situations that can be seen in patients with both autistic spectrum disorder and epilepsy. Let's start with this model, the tuberous sclerosis complex model. You know that this is a very important model for such patients. What is seen is that there are two processes, and the two processes, they may start in fetal life, and one is the epileptogenesis, which is earlier seen, and the other one is the presence of intellectual disability, autistic spectrum disorder. And you see here that between the fetal life and the early childhood, this process is increasing and then it reaches a plateau, persisting for all life. And that's just the representation of a phenomenon. But what are the relationships between those two conditions? You see here is quite complex to make this linear, but you have on one side uncontrolled epilepsy, you have the tuberosides, but the tuberosides also is responsible of the age at onset of seizures, and the age at onset of seizures is responsible of developmental delay, and everything goes back on the autism. So it's a complicated model, but you see here how much there is interaction between different situations, which can be has both biomarkers in ASD and epilepsy, like type of EEG in the type of number of tubers, and and this is something that should be every time considered. We know that earlier age at onset is associated with autistic spectrum disorder in TSC. We know that the patient with TSC and autism have more frequent seizures than patients without autistic spectrum disorder. But also we do know that the overgrowth that is the base of the tuberous sclerosis complex can be definitely on the same level as of those clinical findings. There is different prevalence reported in literature in those two diseases. I'm going to go quickly here. You see here it goes from 6 to 70% depending upon different samples of patients, and it can be even higher, going to 100% of patients depending upon different situations. But another question is that is autism driven by epilepsy in infants with TSC? And you see here you see here that this is a nice review paper, and you see here that the cognition and risk of ASD depending on the early treatment on conventional treatment. And you see that there are no clear-cut differences if you look at the early treatment and the conventional treatment, and definitely most probably ASD can be influenced by epilepsy, but it is part of the disease. And this was also very nicely documented in MRI studies, where you have alteration of connectivity in tuberous sclerosis complex, which is something that should be definitely considered in patients with both ASD and epilepsy. Let me go now through the last one more example that I wanted to make to you guys before moving to the conclusion, as time is running. And this is the CDKL5 deficiency disorder, and in which you have, together with epilepsy, you have abnormal social interactions, repetitive movements, absent speech. And what we know that there is also a significant developmental disability. There are old studies that documented also even 10 years ago that there is a specific interaction with genes that are of CDKL5 with genes that are key candidates in ASD pathogenesis, and therefore here again we know that in CDD almost 100% of patients they do have autistic spectrum disorder, and therefore it can be really part of the disease, a part of this specific interaction, genetic interaction. Also, it's interesting to see, and this is a study that we did recently looking at the cortical volume in patients with CDD, that there is an evolution of cortical volume over time, and with a reduction of different areas of the brain, which also can be considered as part of the disability and as part of the behavioral symptoms. So now let me go to, in the last couple of minutes, to the conclusion of this talk, and I wanted to summarize the few concepts which are interesting for our discussion maybe later. And we have a specific interaction in between the abnormal excitability in the developing brain, the epileptogenesis, and the presence of ASD or other behavioral problems. And this can be based on a disrupted synaptic plasticity and other situations that I already mentioned to you. So as a summary, final summary, just remember that there are gene transcriptional regulation issues, cellular growth, and synapses development, which are affected in both autistic spectrum disorder and in epilepsy. So a really complex mechanism, and we don't have so many information right now. What we know that there are genetic variants. We know that that variants may affect in some way the physiology or the normal physiology of the neuronal development, and our future task should be, of course, understanding the general principles and better understanding the what really those specific mutations are doing, and in terms of neurobiological processes that are behind ASD and epilepsies. There are a few studies in animal models. I didn't show you for the sake of time, but there are nice animal models that there are a few of them, but more and more developing animal models that can be helpful also at the light of targeted medications. And finally, the in vitro models represent an important tool understanding the pathogenic basis of epilepsy. And again, let me point out that the need of a better understanding is related to the possible development of future medications and of targeting the medications for such patients, not only for improving seizures, but to prevent the development of autistic spectrum disorder in such patients. And this closes my talk. I thank you very much for your kind attention, and I will be happy to take your questions. Thank you very much indeed.
And thank you for that very interesting presentation. We have a few minutes left to entertain some questions. So if you have questions, please put them in the Q&A box at the bottom of your screen. Some people have been sharing their personal experiences, and you may wish to read those. Let me see. Let's start. There's a question about treatment, sort of behavioral interference with anti-epileptic drugs. So this case is a child who's 5 years of age, nonverbal, and parents are finding it very difficult to administer medications. Do you have any behavioral suggestions, Dr. Salpekar or Dr. Reilly?
That's a perpetual problem. I mean, how to get kids to take medicines, and it's one of those things that unless you've lived it, you really don't know. Any type of cajoling, bribery, combining sugar, dessert. Sometimes the taste is bad on purpose because you don't want people to kids to think, oh, this is candy or something. But yeah, anything like that to sort of mask the taste or add it or blend it. Most of the time, a liquid-based medicine can be done like that. The other thing is you can get some very young kids to learn how to swallow pills. I mean, the quicker you can get them to learn how to swallow pills, either practice with mini M&Ms or Tic Tacs or something like that, then the better off you're going to be, because then it's one and done. So that's there's no magic, but it's a tough problem.
Thank you. Now, another question is whether EEG, metabolic screening, MRI should be done in every child with autism. Opinions on that? Maybe Dr. Salpekar or Dr. Specchio could address that.
My sense is if there's regression in function, then probably yes. If not, then not necessarily.
Hi guys, completely agree with what Jay was saying. I mean, if you have a patient with a clear-cut regression of abilities, definitely we should we should go forward with MRI or EEG, even 24 hours EEG, trying to record at least 1 or 2 stages of sleep. Otherwise, I would not go for an EEG in a patient where the previous autistic spectrum disorder and then an epilepsy. I don't know if you agree, guys.
Okay, here's a somewhat related question. If a child with autism does not have seizures, but there are changes on the EEG, would you recommend starting anti-epileptic therapy?
I would suggest only if clinical seizures are there. I would not go for an anti-seizure medication in case the patient only do present with EEG abnormalities. Only if clinical seizures are there, definitely I would go for a treatment. Otherwise, I would just wait and see and closely monitor the patient.
Thank you.
That's a tough question. Sometimes if you have symptoms that reflect impulsivity or, mood swings, those are pretty good targets for anti-seizure medicines. Without those and with some abnormality in EEG, then, maybe not.
Okay, great.
That's for sure, Jay, but this is not for seizures. This is for like mood stabilizers. So
Correct.
It's a different prescription. Yeah, okay, thank you.
Jay, while you're unmuted there, here is a question perhaps. Can benzodiazepines cause dependence in children?
Theoretically, yes. Practically, it doesn't happen as much as we would think, especially in prepubertal children. Now, that being said, I get pretty nervous, using benzodiazepines in kids. You have to have real targets and you have to be cautious about it. As a PRN, as an as needed, then it's a little bit more tolerable. As a standing dose, I mean, you've got to be careful.
Okay. Someone is asking about the use of transcranial direct current stimulation. Does anyone have an experience with that or would like to comment on what we know about that?
I don't have experience from my side. No experience. I don't know. What about you, Jay? But I don't have any experience.
Very limited. It's not usually used in an epilepsy population because the result is to cause a seizure or subclinical seizure. That's transcranial magnetic stimulation. It's kind of the old electroconvulsive therapy. Very effective for catatonia, for depression, but it's not commonly used in an epilepsy population just because of the theoretical conundrum. But not to say it wouldn't be effective, but I don't have much experience with it and it hasn't been studied that much either.
Thank you. And someone was asking, and I think maybe Colin, I'll ask you if you can address this, about whether, we sometimes hear that children with autism might have special talents. And do you think this is more or less likely in children with epilepsy who also have autism?
Yeah, children with autism can have, particular specific interests, and they can have specific talents as well. I don't think there's any research suggesting that it's different in children with epilepsy and autism. But I guess in terms of supporting children with autism, it's very important to identify strengths, whatever they are, and to use those strengths in terms of focusing on, learning and behavior. So identifying strengths, whether they be special interests or special talents, is very important.
Thank you. And I think there's one final question here. And that is whether there are specific EEG findings in autism. And I'm assuming this question means not in children with epilepsy and autism, but children with autism who don't have epilepsy.
In patients with autistic spectrum disorders and without a clear-cut syndromic epilepsy, usually what we do see is diffuse EEG abnormalities like spikes and polyspikes and waves, diffuse. But this is something that we do see in patients with ASD without a specific epileptic syndrome. And this is something that is scattered in the literature, is not really systematically reviewed. My experience is just we do see diffuse abnormality. I'm not using the term generalized abnormality because we cannot say that it's really generalized abnormalities, but you see you have frontal bilateral spike and wave discharges.
Thank you. Okay, I would like to thank everyone for your interest in the webinar. Thanks to the speakers who provided their expertise, and to all the participants.